Hello, everyone. Welcome once again. And I would like to thank immensely Pfizer for the organization of the Lung Cancer Connect. I think that it is a great opportunity for all of us to discuss the management of ALK positive NLC-LC, and we can talk about the best options for treatment. And therefore, it is a great pleasure to have Dr. Bauer with us also tonight. Well, Dr. Bauer, he's a physician, oncologist, and he's an investigator of Sarah Cannon Research Institute at Nashville in the United States. And also we also have Dr. Carolina Kawamura. She's an oncologist, clinical oncologist from DASA and 9 de Julio Hospital. Dr. Elano Carioca Freitas, he's an oncologist, clinical oncologist, and chief of the thoracic oncology of AC Camargo Cancer Center. And our event will last for about an hour or so, 25 minutes for the class of Dr. Todd Bauer, and it will be focused in the landscape, the evolving landscape of the patients of the non-small cell lung cancer carcinoma, and 10 minutes for Kawamura, and then we're going to have the clinical case for the ALK positive patient with a focus in the new generation of ALK, and then 10 minutes for Elano Freitas with another clinical case that is also focused in the management and the management of the side effects. So it is my great pleasure, and it is a great pleasure to be here receiving all of you, Dr. Bauer, Dr. Kawamura, and Dr. Freitas. So let's start this with Dr. Bauer. So, Dr. Bauer, if you can already start and you have your screen shared, the floor is yours.
Great, thanks. I appreciate everybody being here. I know it's 8 o'clock in the evening there because this is the second time I've done this at 5 o'clock my time. So I suspect all of you have had a long day in clinic, and I appreciate you spending your evening with me when you could be spending time with family or sports or what have you. So tonight I'd like to share with you a little bit about the evolving landscape in ALK positive lung cancer. We've gone in an era where just over a decade ago, we really had no specific treatments for these patients, to having so many options, it gets very confusing. I'm going to talk to you about lorlatinib and think about use in the first line. And then we're going to talk about the side effects of lorlatinib because it is a different sort of drug. It's a third generation ALK inhibitor. And there was always some question of how is it different? Well, first and foremost, it's a macrocyclic molecule. So structurally, it's different. And that leads to different properties of that drug and how it interacts in the brain and with the cancer. So if you go back, and if you'll remember, the original publication for EML4 ALK as a driver mutation in mice, of course, was published on August 7th of 2011. Crizotinib got its accelerated approval like 4 years and 2 weeks later, August 26, 2011. And then in the past decade that we've had that now, we've gone to full approval of crizotinib, and then ceritinib, alectinib, brigatinib, lorlatinib, and likely soon to be ensartinib. So we have a tremendous number of options. And the most important thing as we look at these options is what's the best way to care for each and every individual patient? Is it give the best drug up front and see what you get? Or is it figure out how we can sequence these to give every patient the longest amount of time possible on these drugs? I think we have to look both at the basic science and the clinical data to drive our decision-making and what's the right first line for our patients. What we are starting to see is this evolution of thinking about EML4 ALK. Not surprising, not all fusions are exactly the same. In fact, we have at least 8 variants that have been described. That has to do with the breakpoint and where that fuses back and forth. If you look across those 8 variants, it's clear that EML4 ALK variant 3A and B and EML4 ALK variant 1 are the largest majority. Probably 2/3 or 70% of patients with ALK have these two. So if we know that those are most of the patients with ALK, can we then differentiate by which drug works best in that space? I'd like to say that this is common practice now. It's actually not. We are still looking at EML4 ALK as just EML4 ALK. But I do think that in the future, whether it be near or far, I'm not sure, we will start looking at these variants and use that to guide us. And here's why this matters. This is called a stoplight chart or a heat map. I, as a red-green colorblind kid, think of this as a cruel joke. But what I can do is look here at the numbers across the top for EML4 ALK variant 1. Crizotinib's IC50 is 23.3. As you go left to right across that, you see ceritinib and sartinib, alectinib, ergatinib, and then lorlatinib. Each one of those numbers, those IC50s getting smaller. Remember, the smaller the IC50, the more potent the drug is against that particular thing. So lorlatinib is 2 log-fold more potent than crizotinib in targeting wild-type variant 1. Again, in variant 3, you see a similar trend all the way down to lorlatinib being the only one in single digits at 4.5. So that's important as we look across this, because that suggests that the best drug from a pharmacology standpoint is lorlatinib at the 2 most common EML4 ALK variants. The other thing that I'll draw your attention to on this slide, if we go down the column of those resistance mutations, the most common resistance mutation against the second generation ALK inhibitors, alectinib and ergatinib, that G1202R, we see that lorlatinib again works very well, has a very low IC50 compared to the other first and second generation ALK inhibitors in both variant 3 and variant 1. So what we see is that based on this data, it appears that lorlatinib is likely the most potent ALK inhibitor against the most common ALK variants we see. This speaks more to me because it's not color-based. It's a very simple bar chart that shows me the differences. So if you look at that ALK variant 1, crizotinib's IC50 is 23, which isn't bad, right? It's a good drug, but lorlatinib's is down at 0.267. So a dramatic difference in those two when you really look at how that plays out in the clinic. And then again, at ALK variant 3, a significant drop off as you go across that curve. And I appreciate Ignatius O sharing the slide and allowing me to use it, because this to me speaks volumes about how significantly better the newer generation ALK inhibitors are against the older generation ALK inhibitors. So we know that all of these are better than crizotinib. We know that because we have 4 studies that are actually quite similar. And my pretense is that the most common thing you will hear at any international meeting is we're not supposed to do cross-trial comparison, but because we aren't able to really do this. But so that's what we're going to do tonight. We're going to look at some of these with all the caveats that go along with cross-trial comparison, knowing they are different patient populations, no matter how similar we try to make them, to try and parse this out a little bit, recognizing, again, it's all with that caveat about we shouldn't really be doing this. So these 4 studies, the ALEX study, which is the most mature of the data, ALTA-1L for ergatinib, the EXALT study, the most recently published with ensartinib, and the CROWN study with lorlatinib, all of them about 300 patients. When we look at that objective response rate, this is the top line data, right? So this was the first data cut for alectinib, showed an 83% response rate versus 75%. So not saying crizotinib's a bad drug, but alectinib's better. Now this was investigator assessed, which is important because when you look at the next 3 studies, all of those were by a blinded independent review committee at that first data cut. You see similar response rates across those 3 studies, about 74, 75% to somewhere between 60 and 67%. Again, crizotinib does work, but these other drugs work a little bit better. Here's where we see those drugs truly shine in the second and third generation. The median progression-free survival hazard ratio for ALEX, ALTA, and EXALT, all about 0.5. Showing 26 versus 10, 24 versus 11, or 26 versus 13. So you get basically 2 years versus 1 year with a hazard ratio of 0.5. When you go down to lorlatinib, and this was probably the biggest impact of this study in the high level data, was you see a 9.3% or 9.3 month progression-free survival, and the median not yet reached to that first data cut, and a hazard ratio of 0.28. So here we start to see a difference between the second generation ALK inhibitors and lorlatinib as a third generation ALK inhibitor, what appears to be a significantly longer progression-free survival based on that hazard ratio. We then look at intracranial response rate, and this is a great problem to have. We have 3 drugs that all have great activity in the brain. Again, we'll look at this recognizing that this intracranial objective response rate with the ALEX study was investigator assessed, where it's on 81% response versus a 50% response. If you look at the next 2 studies, those were blinded independent review. Again, 78 versus 26, 64 versus 21. And then you go to the lorlatinib study, and this is a little bit different, 82% versus 23. So Where we really saw this breakdown different between the investigator assessed and primary or blinded review committee is a 50% response rate in CRIS versus closer to a 20 to 25% response rate. But all of these second and third generation drugs do work well in the brain. Okay, so if they work well in the brain, how do we figure out which is the best in the brain? Well, those complete response rates are where we might see a little bit of difference. Alectinib at 38%, again, investigator reviewed, versus the other three with a blinded independent review at 10%, 27%, and then a 71% response rate for crizotinib. So what we see across these cross-trial comparisons is all of these drugs work well initially. The progression-free survival of the second and third generations is significantly better than that of the first generation drug. When we look at the intracranial response rates, specifically the complete response rate, the complete response rate of the third generation drug, again, is significantly better across trials than it appears in the second generation drugs. This is a great slide that Christine Lovely presented at ESMO 2 years ago, or a year ago, I guess. And the import of this slide is really where you see the third data cut for the ALEX study. Those benefits continue through. So this isn't a quick benefit that goes away over time and the medians come back together. That benefit continues on where we now have a PFS of 35 months. And that is an investigator assessed difference versus 11 in crizotinib. Now, this I think could be one of the most important slides I present to you tonight, because one of the things that has come out about lorlatinib from its early studies was that it was a hard drug to give and a hard drug for patients to stay on. So let's look at the data as we're supposed to do. If we look at the second column, treatment adverse events related to dose reduction. In the CROWN study, first line, half of patients on lorlatinib had to be dose reduced, but so too did almost half of those patients on crizotinib. Alectinib in the ALEX, EXALT, and ALTA-1L studies, those numbers are different versus not 47%, but 21%, 29%, and 20%. So fewer dose reductions on the CRIS arm, and also fewer dose reductions on the comparator arm, or the experimental arm rather. Alectinib, only 16% of patients had to be reduced, brigatinib 28%, and ensartinib 24%. So that would suggest that yes, lorlatinib does require a little bit more active management on the part of the physician prescribing it and caring for the patient. But this is what I think is really interesting. If you look at how many patients had to come off of the drug due to the treatment-related adverse events, only 7% of patients on lorlatinib, similar to 9% on crizotinib. And then you look at alectinib, brigatinib, and ensartinib sequentially, 11%, 12%, and 9%. So all the caveats across trial comparison being what they are, it does not appear that more patients have to come off of lorlatinib than any of the other second generation ALK inhibitors, and not significantly more than crizotinib either. So yes, it may require a little bit more of our time and understanding. It doesn't appear that patients can't tolerate it. So that's really important as we talk through these next slides. So we've looked at some of the basic science. We've looked at some of the clinical trials. How do I think about this as I'm trying to care for my patients? Well, we know that 30 to 40% of patients with ALK-positive disease will present with CNS metastases present at baseline. And of that 30 to 40%, or I'm sorry, 60 to 70% that don't present with it, over a third of them will have metastases within a year. So that has to play a role in our thinking. Can we parse out this PFS data to see where that really is impactful? Well, this is the median PFS by blinded independent review, the hazard ratios. So again, everything's up at about 0.5 for those second generation drugs, alectinib, brigatinib, and ensartinib. And then you see that 0.28 for lorlatinib. When we go over and look at patients who did not have brain metastases present at the time of diagnosis, with the exception of brigatinib, the alectinib and ensartinib come a little bit closer to lorlatinib, and it looks a little bit less good maybe, suggestive that we see more progression below the shoulders in these patients. When you look at those patients with brain mets, lorlatinib actually looks even better. They don't progress in the brain, whereas with the others, we do see more progression in the brain. PFS speaking. This is what it looks like at 12 months. Only a 2.8% cumulative incidence of progression in the brain on lorlatinib. So it is very protective of the brain. Crizotinib, on the other hand, a 33% incidence of CNS metastases at 12 months. So clearly, if brain metastases are a problem, which we know they are in ALK-positive disease, lorlatinib works well to protect the brain. Now, I've said that lorlatinib is a third-generation drug, and it is a different drug, and it does have different side effects. The most common side effects that we deal with are hypercholesterolemia and hypertriglyceridemia. Those are pretty easy to manage. I want you to think about those. We're going to talk about those in a minute. But think about those just like you think about hypothyroidism in a patient on an immune checkpoint inhibitor. You see their TSH go down, you know it's going to rocket up to 7 or 8, and you don't stop the drug. You put them on Synthroid, you manage that, and that's exactly how you manage the hyperlipidemias we see on lorlatinib. In general, for grade 1 toxicities, you can either continue lorlatinib at the same dose and try and medically manage it, or you can hold it, let it resolve, and then re-challenge at the same dose. If they go to grade 2 or 3 or moderate or severe side effects, that's when you would want to think about holding lorlatinib until it gets better and then reducing the dose immediately on re-challenge. If we see a grade 4 toxicity, that's when we have to talk about permanently discontinuing lorlatinib. So now, what we've talked to so far, and this is an important point, has been the phase 1 CROWN data. Going forward with this toxicity management, the numbers I'm going to be referencing are from the phase 2/3 study, the accelerated approval that got lorlatinib approved in the second line. So for this more heavily pretreated population who experienced these drugs a little bit more, the dose interruptions and dose reductions were actually lower than in the first line population at 22% and 20% respectively. The most common causes for those interruptions and modifications were edema at 5.8% and 6.1% of patients respectively. Then some permanent discontinuation, this more heavily pretreated, more experienced population was only 2% versus, remember, we saw it up at 9% or 7% rather in the phase 1 data. These were for cognitive disorder, mood disorder, 2 apiece, and edema and fatigue in 1 each. Now, Ignatius put together this great slide that shows when we start to see these. There are reports of acute psychotic issues with lorlatinib. Those happen very quickly. I have fortunately not had to see those yet, but I know that they can occur. Those happen quickly. What we start to see accumulate over time are the hyperlipidemia, slowed speech, weight gain, and peripheral edema. I show you this slide. It's very busy. Please don't try and read every word on it. Mainly to focus in on the major side effects that people worry about, cognitive and mood effects. And I think I use this slide to remind you to please incorporate your patients' caregivers in their care. We only have the time to spend with our patients. For me, unfortunately, it's only 15 or 20 minutes for a patient on lorlatinib every month or so when they come in. It's going to be tough for me to perceive a difference in their cognition or their speech pattern or their depression level, but somebody who lives with them and cares for them is going to be much more in tune with that. And so I share with all the patients' providers or who are with them, their caregivers, please let me know if Grandpa Sam isn't wanting to go have breakfast with his friends anymore, or he's sleeping an extra 3 hours a day, because we can manage that effectively if we know about it. And the earlier we know about it, the more effectively we can manage it. So what are these common CNS effects? Well, the main ones are cognitive function, mood, and speech. These are generally mild in severity, intermittent, and do improve with dose reduction or modification. We saw this combination cluster term in 40% of patients, with only 12% of patients experiencing at least one or more. Now, one thing that has to play into our thinking of this is 72% of the patients on this portion of the study had brain mets present. And a number of those patients had treatment of those brain metastases with radiation in the past. One of my patients who I've cared for on this drug for over 7.5 years with ALK-positive CNS metastatic brain disease has been on lorlatinib for 7.5 years. He had whole brain radiotherapy in the spring of 2014. I don't know what those side effects truly look like in patients at 7 years, because he's the only patient I've seen survive that long after whole brain radiotherapy. So I think we have to take that into consideration as we take into account these CNS side effects as well. Now, 24 patients did require at least one dose reduction as a result of this. 15 of those patients did experience resolution of the side effects. The median time to resolution was about 13 days. There was some recurrence, even if the dose was reduced at 6 and 7 patients for no dose reduction and dose reduction. Here's a Venn diagram showing the looping in of those. So only 6 patients, or 5.1% out of the 117 patients included in this, had all 3 of those. In the management, if it's grade 1 and you discuss with the patient, you can continue on at the same dose. If they want to take a break, it's okay to take a break and then try and re-challenge them at the same dose level. Some patients see resolution without recurrence. If they do get to grade 2 or 3, moderate or severe, where it starts to interfere with their life, that's when we do recommend holding the dose and resuming at 1 dose level lower. I'll remind you here that the primary starting dose is 100 milligrams once a day. The first reduction is 75 milligrams once a day. The second and final reduction is 50 milligrams once a day. If they do have grade 4 CNS effects, it's recommended that lorlatinib be permanently discontinued. Now, Ben Solomon gave a great update of this data. This was from we shift back here to the phase 1 data. This was at ESMO just back in September, where we looked at 86 patients with CNS adverse events, or rather 86 CNS adverse events across the patients. He was able to parse out through the data what happens if we did not intervene, how many got better. Well, as it turns out, 28 out of 86 events got better with no hold or no interruption. Interventions range from adding a con-med to modifying lorlatinib through dose interruption or dose reduction, adding a con-med and adjusting the dose of lorlatinib. All that to say that out of the total patients, 56% of patients who had, or 56% of CNS adverse events rather, did resolve with appropriate management. Whether that be no management at all, you continue doing what you're doing, or you have to go all the way to permanently discontinuing lorlatinib. So 3 patients had improvement. Only 38% of the adverse events didn't resolve. Most of those were without intervention. So that might be somebody who has a grade 1 slowed speech pattern, and they just continue on and they're okay with that. So well managed with dose reduction is the message to take home from that. Hyperlipidemia, again, I just tell my patients to expect that they're going to be started on a statin. Median time to onset is 15 days. So I do check it prior to starting lorlatinib at 2 weeks, 4 weeks, and monthly thereafter. We saw elevations in 82% and 60.1 or 60.7% in cholesterol and triglycerides, respectively. Most were grade 1 or 2. These were not common reasons for dose reduction or delay. As I said, you just treat through it, and no permanent discontinuations due to hyperlipidemia. We've addressed that. This is important though. Pitavastatin, pravastatin, or rosuvastatin are the preferred statins to start because of their low interaction with CYP450, which can worsen the side effects of lorlatinib if you add in something that interacts with CYP450. So don't use the older generation, just pick rosuvastatin and go with it. It works well. We've talked about the monitoring and how we can manage it. 2 more recently described, and then I'll wrap up, I think pretty close to time. Hypertension, hyperglycemia. This has come out of some data we've seen in the EU more recently, where we saw 13% all-grade hypertension and 9.2% all-grade hyperglycemia. The management of these is just like we've talked about managing everything else. If it's grade 1 or 2, you can use con meds to manage the blood pressure and the blood sugar. If you can't manage that, you may have to hold lorlatinib until it gets to grade 1, maximize your medical management, and then reinstitute lorlatinib. Look, if we get to grade 4 and they're on 3 antihypertensives and you can't control that blood pressure, then it may be time to discontinue the lorlatinib, similar with the blood glucose. I believe that is my whirlwind tour of the phase 1, or the first line rather, data for lorlatinib and the 2nd and 3rd generation ALK inhibitors, and the management of those somewhat new side effects from lorlatinib. So I will pass the control back to, I'll leave it on my screen, but pass it back to the management team.
Boa noite a todos. Obrigada, Pfizer.
Hello. Well, thank you, Pfizer, for the opportunity. It is a great honor to be here with our colleagues, Todd Bauer, and to be able to share our experience. I'm going to present a clinical case, real world. I am Carolina Kawamura Haddad, oncologist from DASA Group. These are my disclosures. So you can see this is a 41-year-old female patient, never smoked. And this is a case that started in 2014. She presented with a cough, fever, and pain in the right scapulary region. She was treated with a pneumonia. She had a change in the X-ray, but she resolved the fever, but there was still the coughing, and eventually she was investigated with a CAT scan and bronchoscopy that revealed a vegetative lesion and a complete obstruction of the higher lobe. And we biopsy this, the results anatomopathologic. This is an adenocarcinoma, solid pattern, TTF1 positive, Neptune A positive. At the time, we did a panel restrictive just with EGFR and ALK by FISH, and both were negative. Patient had the MRI, cranial, and then we have the two lesions in the central nervous system. The patient always had done also did a PET. We did the pulmonary mass and the RUL, 7.2 centimeters, enlarged mediastinal lymph nodes, and supraclavicular LNs, and two liver lesions that are suspected to be secondary. So remember that we are in 2014. The patient is lung adenocarcinoma, EGFR ALK negative, post-obstructive pneumonia with this pattern of dissemination of metastasis to brain lesions that are asymptomatic. We requested, therefore, a broad test, NGS. The result was pending. And at the time, we started to do the chemotherapy with cisplatin, pemetrexed, while we were waiting for the next generation sequencing. And then she was irradiated palliative for the pulmonary mass, and the brain was followed up, and she was stable. She didn't have any progression of the disease in the central nervous system. And then we received the result of the NGS Foundation 1, and then we can see that there is diffusion, ALK, LM, ELML4, variant 3, and then we had a negative FISH, but that shows that in fact we need to broaden the research for these young patients, non-smoker especially. So here we are at the beginning of 2015. At that time, there was no ALK inhibitor approved for Brazil, and fortunately, that patient was included in a compassionate use program for ceritinib, the ALK inhibitor second generation. The patient had some, gastrointestinal effects. You can read on the slide. There was a discombination of dose. Ceritinib was used in a dose that was higher in without food, and that changed. We changed the prospect, and the patient could keep the use with a good response, systemic, and with the stable disease in the central nervous system for a long time. So here I'm reporting how the history was of the brain story. So we had an excellent partial response, systemic, but in the central nervous system. Therefore, she kept the use of ceritinib from May 2015, August 2016, with a stable CNS disease when she presented the progression of the disease. And then it was the first time that she did the radiotherapy, radiosurgery in the occipital and parietal lesions. And then eventually she had to irradiate another lesion of the cerebellum. And then 2017, we had a few other lesions for the parasagittal, temporal, occipital. 2019, a new lesion that ended up being irradiated. And during all of this period, she kept stable from the systemic standpoint, only progressions in the central nervous system. She developed even a radionecrosis, and then we did the entire evaluation with spectroscopy and perfusion, and she used bevacizumab for this necrosis. I'm going to show you the image, and you can see here the image of the radionecrosis of the patient that was a good treatment with bevacizumab. So we come back to this story. She ended up having to do a resection because of a lesion in the cerebellum, and then she had the progression of the disease in December of 2020. And then she had the tumoral base irradiated, and then we used this opportunity to try and do a new test from Foundation 1, and actually we saw that there wasn't any mutation in ALK as a trigger for resistance here. Actually, she kept the original pattern. So we opted to continue with the treatment with ceritinib, and now in October of 2021, she has a progression of disease in this region, occipital, and also in the insulary region on the right, in the insula, sorry. And this is the pattern of the other lesions that were irradiated. So we had a broad discussion, multidisciplinary, in regards to what we should do. She was seen by the neurosurgeon, and she thought that it was factual to do the resection of the occipital lesion, but not the insula lesion. There might be a sequela, a neurologic sequela risk. And then we proposed to the patient that she would do whole brain radiotherapy. The patient is resistant to the radiotherapy for the whole brain since she doesn't have any symptoms. For as crazy as it seems, she doesn't have neurologic symptoms up until now. So we decided to start lorlatinib and to follow up very close. But I confess that I am a little bit concerned, and if I was going to decide by myself this case, maybe I would have started radiotherapy, whole brain radiotherapy at this time, since the lesions are broad, big, and any escape will be very challenging for the patient. But, this is a joint decision to start with lorlatinib and to follow up very closely and to define the next steps up ahead. And that's it. That was the case.
What a fascinating case. I mean, that's amazing.
Concordo.
I fully agree. There was many years of follow-up, and it was only possible, really, you can imagine at a time that we didn't have any equipment, that it was any medication. That was the first ALK inhibitor that was approved in Brazil. It was 2016.
Amazing.
Posso começar minha apresentação?
So can I start my presentation? Yep, you can.
Compartilhando a tela.
So I'm sharing the screen here. You can see the screen.
Bom, eu vou, nos próximos
Well, I'm going to, over the next 10 minutes, to present another clinical case. I also thank the opportunity to be here with you to discuss with people that I really enjoy from Brazil and that I admire. Dr. Bauer, also thank you for your experience. And here are my disclosures. Well, I'm going to present this case in a patient that is 74 years of age, and she started in 2019 with a pain in the chest, and she was looking for the physician. She did a few exams. We had the paralysis of the vocal cords, and there was a lesion that obstructed a part for the left lobule, and the biopsy revealed an adenocarcinoma of the solid and pulmonary pattern. And at the time, we had a restrictive panel that had very few genes, and we did ALK by immunohistochemistry in the Ventana kit, and she had PD-L1 10%, so it was positive. So immunohistochemistry, we don't know what the variant was up until that time. Now, the staging exams, she had a brain MRI without the evidence of disease and a PET with multiple lesions. Pulmonary lesions, hepatic masses, confluent, large volumes, and several foci of bone disease. You can see a few more images. And we have the pulmonary mass, the mediastinal lymph nodes, the contralateral, the confluent masses here in the liver. So the patient with a lot of, a large volume of disease. And surprisingly, she wasn't that symptomatic, but she had mainly cough and, a raspy voice. And well, we had 2019, the only second generation approved at the time, alectinib. We had crizotinib and we had alectinib of the second generation, and all the other ones were not approved yet. This is the patient that we started with a good tolerance, and there was a good response. First evaluation of the response, December 19, and a partial response that we see practically the disappearance of all the captures here on the PET. You can see very markedly here where she has a lot of disease in the liver. So we decreased the capturing. We still saw in the MRI some images, so it wasn't a radiologic complete response. She had a partial response. And in a very surprising way, actually, very early on, from 6 months of the onset of the treatment, the patient started to see the progression of the liver disease. Absolutely asymptomatic. So this is the PET of December 19. And you can see of the points that she had captured in the PET, we only captured again the liver ones. So there was these hepatic lesions. We were discussing with her at the time of 2019. In the early 2020, we didn't have the approvals still for other second generation inhibitors, and it was approved right after. And the patient didn't want to do chemotherapy. So we discussed the risks and the benefits for keeping the patient with the use of alectinib post progression. And in June 2020, sorry, 9 months of treatment, she had continued to have a progression, but she hadn't advanced so much. She was still asymptomatic. And the discussion was the same. So at this time, we already had the approval of brigatinib and lorlatinib here in Brazil, but they were still not, commercialized. They were still registering the price. Once again, the discussion of chemotherapy, the patient didn't want it, and we kept the use post-progression for this patient. In September of 2020, we had a massive progression. You can see here, we talked to her, and we did a hepatic biopsy and liver biopsy. So we had brigatinib and lorlatinib available. And the biopsy, you can see in the liver, we discovered that she had the variant 3 of ALK, and the mechanism for resistance is G1202R. So it wouldn't make sense to use a second generation inhibitor, so we switched to lorlatinib. And the patient tolerated very well at the beginning, in the first months, absolutely no neurologic symptoms. And she had a response that was very important in the liver. Partial, residual nodules, but all the captures were disappeared. And she was a lady that, regardless of the pandemic, she liked to run away to go to the supermarket. The family hated that. She did everything that she wanted in a normal way. And thereafter, in a very surprising way, maybe less time than what we would expect with a second progression, she evolved again with a progression in the liver, always a progression in the liver. There was no evidence of bone disease or other type of disease. And she continued to not wanting to do the chemotherapy. We did the liquid biopsy to avoid the liver biopsy. And the mechanism of resistance is a compounded mutation, G1202 plus G1269A. Unfortunately, we do not have treatment specifically for that, and no clinical study open for any situation of that sense. And we finally convinced the patient to start chemotherapy. So the patient with a very challenging case, because it's a variant 3 that responded very short time. We had a good response, but not lasting to the second generation inhibitor. And in the same way, she responded for a short while for the third generation inhibitor. In terms of tolerance to lorlatinib, she had, you can read, hypercholesterolemia, a grade 2, managed very easygoing with a statin. She took rosuvastatin. She had fatigue, asthenia, light. She had an edema. It wasn't that cumbersome for her activities, but it was a degree 2. And she started with something that is not very commonly described, but there are reports. She started to have proteinuria with an occasional finding of urine type 1. We went to a proteinuria 24 hours. She had proteinuria non-nephrotic at the beginning, less than 100 milligrams in 24 hours, but it was climbing up all throughout the months that she was using. And after she stopped using lorlatinib, there was a reversal of the proteinuria. She had no more proteinuria. And we attribute that to lorlatinib. So for the outcome of the case, we convinced finally the patient to do carboplatin pemetrexed. She's tolerating very well, and she's responding once again. She had a improvement in the liver lesions in the first evaluation of the response, but let's see for how long it will last. I hope that it lasts longer for her response. Thank you very much. Thank you very much, Dr. Bauer, Dr. Kawamura, and Dr. Freitas. Now, I think that the class was fantastic. Congratulations. We really had a broad depth on the first lines of treatment and the side effects. And the cases were very challenging, very interesting. The case of Carolina with the outcome of 7 years already, and Elano with a biology that is very different. So, well, I'm going to start, therefore, here with a question. And I'm going to start with a question for Dr. Bauer. So, Dr. Bauer, in regards to the management of the first line, in these patients ALK positive, metastatic, with the management in the first line, do you end up taking, into consideration for the choice, really, trying to, take into consideration the central nervous system, the issue weighing down when prescribing lorlatinib or alectinib, brigatinib? Do you end up taking into consideration other clinical factors or molecular factors even in consideration in the choice of your treatment or not? Or is it more because of a preference of the physician and the central nervous system? So the volume of disease in the central nervous system, just that.
Great question. And again, I'll reiterate, Dr. Freitas, you had a great case as well. Neither of those were easy to manage, and both of them were managed like mind-blowingly well. Dr. Ferris, you've asked a very difficult question. It's sort of literally, as far as these pharmaceutical companies are concerned, it's $1 billion question. What's the right sequence for these? And I can think about it in one of two ways. One way says, we owe it to our patients to make sure we sequence the drugs such that they have the most treatment options available for the longest time, right? If I can get 3 to 4 years out of alectinib and then still have lorlatinib there to treat them, that's not bad. And that's as a treating oncologist, that's a warm, fuzzy feeling, right? To know that you have something if you have a good plan B. The other option is to say, we don't bring Pele in off of the bench, right? You put Pele in to start the game, to win the game, so you don't have to try and come from behind. And that's the argument to use lorlatinib first. I really, truly think it is, based on the preclinical data, the most potent ALK inhibitor on the market today. So especially in a patient with CNS metastases, and in a world where no other cancer are we talking about holding our best drug back for a rainy day, right? Everybody gets the best drug up front. My tendency is, specifically with brain mets present on diagnosis, to use lorlatinib up front. If they don't have brain mets, then it's a very intense discussion with the patient. That's one of the beauties of what we do, is we have that relationship with the patient to find out where they are, what's their aversion to risk of brain mets versus not, versus depression and asthenia. And what I think that these two cases share in common is, look at ceritinib, and that's sort of a generation 1.5 drug in my mind. And then alectinib. Ceritinib worked great forever outside the brain. And Carolina did a great job looking, do we have an ALK mutation? We don't. So that would suggest that lorlatinib may not work well, but I think it will because that's a sanctuary site where soritinib doesn't get well. So it'll be interesting to see how that patient does. These other drugs do work well. I don't want to sound like I'm saying it's lorlatinib or nothing, because that's not true. Brain met's present. I think you got to give your patient a 71% chance of a complete response there. Brain met's not present. That's the discussion about what their risk tolerance is for side effects versus brain protection.
Legal, obrigada.
Excellent. Thank you very much. And in regards to the case of Elano, well, a question, Dr. Freitas. So your patient, she did alectinib and then lorlatinib, right? Yeah. So do you actually, well, anybody that wants to answer also, you for free, with the presence of the G1202R that was identified initially, and then in the progression, would there be any role, the 1202 in a variant 3 of ALK? Can we use brigatinib at that time or not? Would it be more lorlatinib and it will already give you that punch? Well, I think that the lorlatinib for brigatinib, it's intermediary to poor, the IC50. So for G1202 is lorlatinib. But Dr. Bauer can tell us better because he has more experience.
You caught me offline trying to pull up a slide again. What I'd like to do is, if I can share my screen and figure out how to do it, get back to the slideshow and show you that heat map again. If I can make my computer work. Sorry, my children would be so disappointed in me right now. Okay, here we go. Here's that heat map again. Let's look at G1202R. And I believe that patient, Dr. Freitas, was that a variant 1 or variant 3? I don't recall.
Trace.
Three.
That one I got, trace. So if we look at the resistance, so you come down to G1202R resistance. If you look at alectinib simply doesn't work against that in variant 3. Its IC50 is greater than 10,000, I think, if I'm counting those zeros right. So I would not use alectinib. Brigatinib, though, you might try it. Maybe you try brigatinib with that IC50 of 83. Lorlatinib should still work better, but we know that every patient is individual in that case, and it's not wrong to try it. A question I often get is, well, would you just throw chemo plus IO on these patients, or would you just do chemo? I might actually just add chemo. I would not add an immune checkpoint inhibitor to these patients. It does not work. These ALK-driven tumors do not respond to immuno-oncologics. But I think that this is the best data we have to know what to do with that. And if we could sequence every patient after every progression, this would be really helpful.
Well, that patient of Elano is a patient that has that profile that progresses very quickly. So she started and she progressed to alectinib in 3-4 months, right? So 6 months. Yeah, 6 months. So we have a biology here that is very aggressive. It's very interesting.
Well, and I'll say the other thing is, what a great lung cancer world where we're parsing out the patients that only progress after 4 to 6 to 8 months. Whereas you think about a decade ago, it was everybody was progressing immediately on treatment, right? Helena, what was the second mutation that patient developed? I don't remember off the top of my head.
G12.
So it was 1269A.
So it's this bottom row, if you look at this heat map, right? So again, it would seem that this patient had a G1202R and a G1269A. Alectinib's probably your best, or brigatinib rather, is probably your best bet to try and treat this patient with another ALK inhibitor. So maybe you put them on brigatinib plus chemo and see what you get.
Uma pergunta.
Well, a question then for you. the compound mutations, they individually, they're sensitive to lorlatinib, but when they come together, they are tumor resistant. So wouldn't that make the same thing with brigatinib?
It very well may. And my logic in saying that I would try regatinib next is if I've got a chance to keep them on a targeted therapy, and maybe it's got a 20% chance of working, right? Do I try for 2 months on brigatinib, or do I give up on ALK and go to chemo that may also have a 20% chance of working, but more side effects? So maybe I give them a couple months on another ALK inhibitor just to give it a shot. And then if I'm really forced, then I switch it to the chemo option. Well, speaking, I'm going to go on a tangent. Forgive me on this, but Carolina, the one point that your case made that I'd like to go back to is the way that you continued suritinib in this patient and used stereotactic radiosurgery to treat these individual things that popped up. Tumor heterogeneity being what it is, this is an excellent example of how you can sort of, the phrase I use with my patients here in the deep South in America is spot weld. You fix that one little spot that has come up and you continue the treatment that's working on 98% of the disease burden. So that's a great example of the way that I think about managing these patients, where you have almost an oligo-progressive disease.
Perfeito.
E é interessante também.
And it is very interesting in this case of Carolina, because here we have seen more and more that your role of the reprofile of the tumor the whole time, I mean, in progression. And in this time, your case, Carolina, it's very difficult for you to actually do that evaluation of the tumor, which today is in the hands, when the patient has a systemic disease, it's all there. And in your case, we wouldn't have the possibility, right? She doesn't have systemic disease. She has central nervous system. It's more difficult for you to do that evaluation by liquid biopsy, right? So anybody has any type of experience, do you have any experience, any of you, in doing the reprofiling of the tumor in these cases of brain-only disease? Well, I tried twice to do the liquid biopsy, and she really didn't have ctDNA enough to do the NGS. The only opportunity that she had was really when we did a neurosurgery with the NGS in the tissue that we collected. Right. Yeah, unfortunately, this is very difficult for us. And another question then, do you take into consideration, and as in the scenario of EGFR, more aggressive where there is a mutation TP53, do you take that in consideration for example, with a co-mutation with TP53 in ALK positive and ALK positive, RB1, trying to take it more to off-target, resistance off-target there that is going to develop? How do you see these patients? Dr. Bauer, first.
Good. Thanks for letting me go first with that really simple question to answer. What I'll say is we currently don't know how these concomitant mutations affect it. I think one thing that's interesting from Carolina's case is that when they did resequence it, all they found was the EML4 ALK fusion, right? We didn't see a resistance mutation. If you look at data that was published by Alice Shaw and our investigator group, if you're able to find an ALK resistance mutation, the response rate was significantly higher than if they didn't harbor an ALK fusion resistance mutation, right? That's suggesting that they've developed a bypass tract or bypass sequence that allows them to progress. Is that TP53? Is that MET? Is that EGFR? I think we're starting to get down into like literally single digit numbers of patients around the world. So I hope that we can find that someday, but I'm not going to hold my breath waiting for it. The interesting thing about Carolina's case, I think, is though they didn't find a resistance mutation, we know suritinib doesn't get across the blood-brain barrier quite as well. So absolutely in that case, I would try lorlatinib again. Even though we don't find that resistance mutation, there's still a response rate to lorlatinib in that situation. So I think that's the right answer there in absence of emerging data.
Tomara que seja uma resposta
Well, I
prolongada
hope
aí.
that it is a prolonged response.
Bom,
Right.
vocês têm mais alguma pergunta?
Do you have any more questions, Elano, Carolina?
Acho que
I think
é isso. Então,
I think
pessoal.
that's it
Muito
then.
bom,
Well, guys, it was a very good discussion, and we learn a lot, you know, with this heat map that is really, really, it helps a lot in our clinical practice. And
Então, acho que
so
vamos encerrar
I think that we're
aqui.
going to close therefore the event. Thank you very much, Dr. Bauer, you know, Dr. Kawamura, Dr. Freitas. It was a pleasure to be here with you tonight.
Muito obrigado também. Obrigado, Dr.
Thank
Paulo.
you very much. Thank you. Thank you.
Thank
Have a
you
nice
guys
evening.
very much. Great session. Appreciate the support.